within the settings that we have. So what does it take to achieve some of the eliminations that we are talking about as a people, as a country, as a region? If we prioritize diagnostic integration to strengthen and optimize the health systems, we will be able to achieve some of the priorities that we want to achieve. If we take the opportunities that are available, for example, if you look at the molecular space, where you have programs that have already been developed, you have networks that have already been developed, you have lab infrastructure that is always available for us to use. These ones will always support the elimination programs that we have within the region. The other thing is collaborating with partners. Collaboration is key because we all can't do things on our own. So we need to hold hands together. And from this, we collaborate with partners who have capabilities, technologies, tools that can enable integration across the diagnostic pathway. And that's when you're looking at supply chain systems, which is very critical. You are looking at LMIS systems for data, because if we don't collect data very well, then we will not be able to have enough information to support the integration that we all aspire. And the other thing is also capabilities. I mean, the world has become a village nowadays. We can collaborate with partners who can support, build, strengthen, and at the end of the day, give us the opportunity for us to be able to do these things on our own. So what are some of the benefits that integration brings to us, either from the MOH space, from the donor space, from policymakers? There are a lot of benefits that integration brings to a country or a program or a healthcare system, if you can call it. Number one, it provides diagnostics in a one-stop shop. So we don't have to spend, or the patient does not have to be sent to different places for them to afford or get services for a test. The other thing is it helps programs or even ministries of health to respond to global infection crises, pandemics, and outbreaks. I'm sure I will have a slide to talk about COVID, but I think that is the most recent pandemic that, over recent times, that I think all of us seated in this room have experienced. And we all saw what and how the countries responded. If it were not for integration, we would be in a lot of problems and will not have achieved some of the benefits and the gains that we did achieve during COVID, despite us losing also so many people on the way. Integration improves efficiency and turnaround time. And efficiency here is, of course, looking at the processes that are involved in providing a test for our patients. Turnaround time, I'm sure this is something that we've all talked about. Turnaround times are very critical in patient management. And if you have a longer TAT time, it means everything is delayed. It lowers costs of instruments across, because of using existing platforms. So that dollar that would have been used to acquire new systems, do a new infrastructure, can be saved from the integration framework. Lastly, it lowers the test costs. So these are some of the things that, when you look at it in a wholesome, are the benefits that you will get from having a well-implemented laboratory integrated system or a multi-disease testing network. So how would a network that would implement a multi-disease testing look like? So you have the national program or the MOH sitting above. They will develop testing policies, treatment guidelines, commodity and supply chain systems, data management systems that can be shared across. If you look at the health facilities, they will implement treatment guidelines. They will, of course, do demand creation, which is very important, and the sample referral networks system that needs to be put in place. And then you have the lab itself, where the testing occurs. So here is where the integrated testing will be implemented. Of course, tapping into the sample referral networks, incorporating the LIS systems for results transmission, and at the end of the day also looking at the quality management systems that are very important to ensure that whatever that is being done in the lab meets some standards that are acceptable and can be used to manage the patients very well. But above all this, there is the instrument itself or the devices that we use, because those are very critical also for an integrated testing to support a multi-disease testing scenario. So these devices, it's important that they are coordinated. It could be by MOH or either a regulatory authority with approvals. Site selection is very critical so that you place the right instrument at the right site. Looking at how will we deploy quality management system for these instruments, because having instruments is one thing and maintaining a quality management system for the instrument is also another thing. Inventory management, that will also help us manage our supply chain system. And at the end of the day is data management and integration. So all these aspects are very critical when you're looking at the devices that are going to be used to support either, if you call it integrated testing, or the multi-disease testing system that we are talking about. And above all these, the most critical thing is to share innovation across the disease areas that we are trying to manage. So here you have best practices, technology, health system innovations that can improve access, because the most important thing is having a well-elaborate access system that can support all these tests or programs that we plan to have. So this is how the journey will look like in a nutshell. So underlining it is the network. And just to show you how things flow from the program right away to linkage to care. So these are different players that come in between, which are very critical to support an integrated testing system when you deploy a multi-disease testing setup. I said I was going to talk about COVID. It was a disruption, actually, to our way of living when COVID happened, and I'm sure there is no any part of our life that was never touched by COVID. Every sector of the global economy was touched. But there was a silver lining with that also. So it accelerated some of the things that we've been talking about for over and over, like strengthening the diagnostic infrastructure. I am sure sometimes 2 years, was it 2 to 3 years back, there was a lot of need to have systems that are able to support testing of COVID. But out of that, a lot of systems came up, not only testing COVID, but also incorporating the existing diseases that we were testing before. This led to what? Integration of testing services. So you'd have samples being done for COVID, HIV samples being done, MTB samples are being done at the same time with the same systems. And this actually showed us it is possible to integrate some of these things very well. There was a lot of capacity building and training that happened. I mean, look at it across the healthcare system. A lot of trainings, a lot of sessions on how to manage the patient. Every now and then, there would be releases from either WHO, in-country seminars, in-country talks that supported and built capacity in order to manage the patients. And a lot of it was the co-infections, especially if you look at the diabetic patients, if you look at the patients who had asthma, if you look at patients who are having chronic diseases, all this, yeah. There was a lot of innovation and research that happened that time. If you flash back, there's a lot of innovation, especially here in Kenya, where there was an issue with the oxygen systems that were not enough. So some individuals from the universities came up with systems or instruments that can be used to support the use of oxygen, which was very critical at that time. Policy and funding, there was a lot of change, there was a lot of improvement. I mean, a lot of things had to be reorganized around COVID. And lastly, there was a lot of heightened and increased public surveillance and data management, especially for diseases. And governments collected a lot of data during that time, which also increased the capacity, improved the infrastructure, and also showed people how to do things quickly in a very short period of time. So if you look at, in summary, some of the recommendations that are being put across, and these are just some of, or a few of them, they are not exhaustive. If you look from the WHO perspective, integrated disease management is very important. Strengthening laboratory system is very critical. Multiplexing testing for HIV co-infection is also very important. From the CDC aspect of view, routine screening of co-infections is very important because this has to be done consistently because of the opportunistic nature of the diseases that we are handling. Near patient or point of care testing technologies, not only concentrating on the high volume sites, you are looking at the whole healthcare system, right from the clinics all the way to the referral facilities. What kind of testing testing systems you can deploy, which is very, very critical. And leveraging on technological advancement. I mean, nowadays information can be shared very quickly, seamlessly, and it should be available for it to be used for decision making. So from a Roche perspective, what is our view on the future of diagnostics, and in particular, the role of multi-disease testing? And from us, we think that implementing a multi-disease testing system within a country will improve in disease detection. So you have a comprehensive disease detection mechanism. So you are not left by just sending the patient in so many facilities just to get tested for things that can be done in a one-stop shop. It will strengthen public health surveillance, which means there's a lot of data that's going to come out from it that can be used to support a lot of decisions that needs to be made. It will lead to improved patient management and outcomes. And from here, you look at the whole care and treatment program. You have a system that the patient can get all the tests that they need to be done within one place, which means they will not default. They will always get all their results in one place, which means managing them, it becomes very easy. Operational efficiency and resource mobilization is also another benefit that multi-disease testing will give, which means you're consolidating, you're getting value for money for all the processes and the testing that needs to take place, and also in acquiring some of these instruments. Technological advancements and innovations. With multi-disease testing, there's a lot of technological advancement that is happening now. If you look at things like the next generation sequencing platforms that are coming up, which most of them or some of them are open, that can be used. If you look things like automation, digital health, all these things are coming up because the availability of information can be used to come up with some of these things very quickly and easily. Capacity building and partnership. With this, you have a lot of human resource issues. You are able to cascade trainings. You are able to look at the whole system and see where can we really train, where can we have a lot of benefit, who needs to be upskilled, and it becomes easy for governments or for MOH systems to be able to deploy some of these things. And it also makes the people who are using these systems to know more. I mean, in terms of just managing all these disease areas. So it is making them become more relevant, especially the work they do. Lastly, but the most important thing is all this will lead to a global health impact, which we are all working towards, and that is reduced disease burden to all of us. These are some of the countries that have managed to practice or implement multi-disease testing. We've listed Kenya there because we know there are systems that are able to do HIV, COVID, and MTB at the same time. We have a country like Uganda, Nigeria, South Africa, where integrated testing has been done in a large scale, and they have been successful. India has also done the same, and Brazil. So these are some of the examples. This list is not exhaustive, but these are some of the programs that have managed to integrate testing within their settings. And that's the end of my presentation. Thank you very much.
So thank you very much, John Abuau. I was getting worried about time. Nikakumbuka tuko Mombasani, Mombasa hamna haraka. Then I also looked at the program and realized it's ending at 9 p.m., so we still have time. That said, thank you very much, John, for reminding us about the World Health Assembly resolutions related to diagnostics, the needs and the benefits of integration, the integration journey, the impact of COVID-19, how positive it was, and finally telling us about the future of diagnostic from your perspective. So at this point, we want to transition and get to the academia. I think right from the first day, Professor Ndwati has been insisting on the role of the learning institutions on building capacity and looking at issues of integration. So allow me to invite a very distinguished colleague, Dr. Jared Mecha. I won't attempt to read the whole profile. Suffice to say that he is a senior pulmonary physician at the Kenyatta National Hospital. He's a lecturer at the University of Nairobi. He's been a program lead for many PEPFAR-funded programs, both in Nairobi and Central Kenya. Karibu sana, Daktari. Let's give him a hand as he comes, until he comes, until he comes, until he comes. Karibu.
Yes. How do you use this thing? So, good afternoon, everybody. Thank you to the organizers of this summit for inviting me to make this short presentation. I suspect I'm making this presentation out of a conversation I had with the head NASCO, Dr. Wafula, a couple of months ago about this little lab that is doing quite a bit of stuff. About 3 years since it last received funding, and therefore the story of sustainability, that we can continue to do useful work even without direct external funding. So what was really the first motivation for this lab? This lab is based at the University of Nairobi Faculty of Health Sciences, and been supporting various activities, but it was inspired by an evaluation of data out of one of the programs that we were supporting at the time, really looking at NCD, comorbidity, and multimorbidity, and you can see that the year there is very deliberate. This story of integration has been going on for quite a while. And here what we were looking at were really what was the burden of NCD, multimorbidity and comorbidity in ambulatory settings. And as you can see, which is data that is consistent with what has been presented here, is a really huge proportion of patients, particularly from what you may call at the time, we used to call, I think right now every cohort is mature, but what we could call at that time a mature cohort, a huge burden of non-communicable morbidity. And these are patients at the time, you will recall, the emphasis was on TX-new. Are you putting people on patients? There wasn't really an emphasis on what are the other challenges that the clients were going through. There wasn't any investment in the systems to support these issues at the time. And for those of you who've been around for a while, will recall that really this was a no-go zone with regards to utilizing program funds to support these patients. So this is outpatient. Then we did the same thing for inpatients, which was even more worrying. So remember at the time, and I think until we started talking about advanced HIV disease, there was also really no emphasis on what happens to the patients that have severe disease, who require hospitalization and require advanced tests. And here, what we looked at was data of about 450 patients, and looking at what were the reasons for admission. And you can see the challenges of really very severe presentations within our hospital setting. What was more worrying was the mortality associated with this presentation, up to 50% mortality. And yet this is really a group of presentations that did not have direct program support. And looking at service delivery partners that were receiving this support, there was really no way that these conditions could be supported, these patients could be supported for the kind of things that were required. So you needed advanced diagnostics, you needed advanced advanced therapeutics, and so on and so forth. We will not go into the details of that, but it's apparent from this data. So this is really extracting the data from the same patients, where you dealing with a huge mortality. So what we were facing was a situation where you have multimorbidity, both infectious and non-infectious, that had limited support from this stream of funding. So the only way you could really support this group of patients was to integrate and uplift the level of support that was coming from what you may call the general health service. We did data extraction for the same for children, and this is what we found. So children also presenting with multimorbidity, and also suffering really extreme or excess mortality, 35% mortality, slightly, you would say, better than in adults. So 10 years later, you do a similar survey, because obviously now you have much better data in close to 70,000 patients. And what you find are really high occurrence of diabetes, of hypertension, and most of which is uncontrolled. So you then triage these patients to provide additional support, and this is support that is really coming from this laboratory system or laboratory infrastructure that has been built to address these specific advanced needs of these patients. And what you find, a significant proportion of these patients triaged out actually have unrecognized renal disease. They have dyslipidemia, and both in terms of LDL cholesterol and total cholesterol, as you can see here. And these are conditions which all of us can agree are minimally supported within what you may call a general health system. So this laboratory was inspired. The motivation was to have a lab that, one, could provide support for advanced care, in that service delivery partners had deficiencies in addressing these advanced needs of clients. Obviously, build or provide a core lab infrastructure for clinical trials and health technology assessment, We've worked very closely with the National HIV Reference Lab, providing support to that lab, and obviously building capacity in what you may call advanced diagnostics, and I'll talk about that very briefly. So this lab, this slide is really to illustrate that this is a lab whose life has continued well beyond direct donor support. So direct donor support ended in 2020. And why do I present this lab? That it is possible for us to build on the massive infrastructure, the massive investments that have been made in building lab systems in this country to sustain quality support for epidemic control, and we'll mention. So this lab continues providing support for viral load, currently supporting about 12 counties in what you may call Middle Kenya. Similarly for early infant diagnosis, and these are the counties that are supported through this lab, really with minimal or no external support. This lab, the other objective was really to bridge the gap in the molecular diagnostic, to bridge the molecular diagnostics gap. As we know, diagnostics are advancing rapidly, and it takes time before the benefits of those diagnostics reach a broad spectrum or a broad range of those that require them. So obviously, you know, there's really limited access to lots of these diagnostics, including currently one that you may be pretty aware about is for purposes of targeted therapies in cancer, where most of the tests are done abroad. And more importantly, in terms of breaching the molecular diagnostic gap, is really helping with training both at diploma, BSc, MSc, PhD, and master's levels, and so on. And this lab has done so. We have various data that effect. So this is an example of support to provide HIV drug resistance testing, especially when you have mold drug experienced patients. The other important aspect of integration is that I think, as Abuao mentioned here, that these technologies it's possible that they can be used for multi-disease detection. So when we had COVID, the same lab very quickly, the only thing the lab really needed to do was put the correct biosafety procedures in place, get reagents, and continue testing. So supported COVID testing and also training of the initial cohort of laboratory personnel to provide COVID testing. Similarly, the same lab, same equipment deployed for HPV testing. So really integration, that the same labs can really be of use with existing challenges and emerging challenges. We continue to provide to sustain what you may call service delivery innovations. You may have seen a poster that where we have developed a solution to improve uptake of cryptococcal antigen testing in the context of advanced disease management, but also improving access to other tests other than HIV-specific tests for patients with advanced disease. So this is the example that you have in the poster over there, where this tool was developed by the team, deployed, and what you have is congruency between CD4 testing and CRAG testing. So the automatic CRAG testing for patients with a CD4 below 200. So really, in summary, integration is possible. Integration is possible, but it's also necessary. I think the data that has been presented here is clear that it's also necessary. But I think there is reason for us to be cautious in this context. One, we have precedents to integration. And the integration in the manner in which I understand it, I mean, Dr. Kimani said that there are many understandings of integration, but the way in which I understand it is integration to address sustainability of the service delivery model that we have now for HIV. That's the way I understand it. So if we all understand it that way, so we have precedents, and those precedents are not very encouraging. And they are also not inspiring. And one of those precedents has just happened the other day, the situation of vaccines. I will not name others. Two, it cannot be a goal. I see it more as a service delivery review or service delivery redesign. So using this illustrative example of this lab, as challenges presented themselves, what we simply did was to redesign the way in which we provided a service. That the gains that we celebrate now in the HIV epidemic in Kenya are actually very fragile. And those gains would need to be protected even as we think about integration, and specifically integration of laboratory services. I may hasten to add that really the viral load test now is not just for therapeutic monitoring, but it's also a prevention tool. And therefore, if we are having challenges of access to viral load, then we are also undermining the prevention agenda. That the integration should be addressed at responding to both population and client level, current and emerging needs. I also indicate that integration cannot be a new initiative. The challenge is how both national and subnational players build on and expand on the massive investments that have already been made. So we really cannot start building a new initiative. And really that there ought to be a flexibility to engage multiple solution providers, both state and non-state, which is what has given us the success that we enjoy, bilateral, multilateral, engage biotech solution providers, and also public benefit organizations and so on. Thank you very much. You saw, Dr. Kimani insists that I show, if you can just very quickly, 2 minutes. Screen, oh yes. So I've had equity referenced here severally. So what's the reference? When we talk equity, what is the reference? And so there are some people who think that the silo that we call the HIV program is what you have on your on your left. And recently, actually, a very senior person says, you know, this program is overfunded. A senior policy leader, I can be a troublemaker sometimes. So that is what is the reference. So when we talk equity, what is the reference? Is it that this silo, that is the HIV program, with the goodwill of friends, is overfunded, or the rest is underfunded? So that when we start talking about integration, we should move in which direction? Which direction would you want to move? Okay? So that is, those are really the hard questions, because this is the choir here. But this choir needs to sing very loudly to the congregation, because I suspect the congregation is not here. The congregations, they tend to sit on big chairs, which currently are empty. So which direction? Integration. So first, equity with what reference? For me, it's equity with reference to, when you talk about all those comorbidities, both infectious and non-infectious, they are the comorbidities, they are population health issues. They are not HIV-specific what? Issues. They are population health issues. And therefore, the equity we should be talking about is equity with reference to population health. So that's number one. And two, that the direction you want to move when you are talking about integration, and I think there's been this discussion of quality, is in which direction? Okay? Will integration lead to loss of quality? And the many, the effort that has gone into a very serious program that we have. Dr. Kimani was challenging me yesterday, asking me, because he told me, you know, I think he thought I'm being very pessimistic. But I asked him two questions. One, what is our viral suppression currently? And he had a very ready answer. What number of people are on treatment currently? And he had a very ready answer. But the second question was, we know what the quality indicator for diabetes is. What is the national average for diabetes control in our country? No one knows. Do we want to get to a state where we do not know the viral suppression in this country? Thank you.
Yeah. So thank you very much, Jared. You can see how the people in the academia look at things. For me, I would be more worried, will these two vehicles take us back to Nairobi at the end of the day? And will we reach there? Maybe the comfort is different, but the destination may be the same. Those are my thoughts. So thank you very much for summarizing for us, starting with showing us the burden of NCDs, both at inpatient and outpatient, in a situation where the programmatic is not very keen on the comorbidities and NCDs, the lab support that the university invested in, and the sustainability of the same, that beyond the donor funding in 2022, you continued to have testing that is provided beyond, and the integrations that you have been able to demonstrate for COVID testing and HPV. But your second last slide is actually quite provocative, almost poignant, remembering what Prof. Kimayo also challenged us. He said it's okay to integrate, but plan carefully. And when I listened to you, you said we need to be cautious because previous experiences are not always very rosy. You also told us that we need to not look at it as a new initiative, and also noted as a goal on its own. But at the same time, you told us that we need to be flexible and leverage on multi-stakeholder, all the people in this room, to actually make it work. So I think those are very provocative thoughts that we need to continue thinking about. I think we are coming to the end of the program. We have one last presentation. So before that, I'll ask somebody with a very unique name, Bosley, to come and appreciate the last two speakers, Dr. Mecha and John Abuau, so that we go to the last presentation of the day. Thank you.
Good afternoon. The room is quiet. Good afternoon. Thank you. I don't know how best to appreciate the two presenters, but I want us to stand kindly. So, I will only say the two presenters have done a wonderful job. And by that, I want us to clap 5 factorial claps for them. So for example, how do we do it? I see doctor is ready. Yes, 5 factorial. We start from up, down. So let's go. Let's warm up. I'm looking at those who are not warming up. Maybe they are not appreciating the presenters. Yes, I have a whole class warming up. Let's go, 1, 2, 3. Thank you so much.
So thank you very much. The last presentation, the icing for the cake for today, will be made by my session co-chair, Nancy Bowen. Welcome. Nancy Bowen has been a friend and a colleague for many years. She's been in the National Reference Lab as the head for the last 12 years. Before that, she was in NASCOP for 11 years, so she has a wealth of experience. She's a lab molecular biologist. And why she so fits this session about integration is because you heard John Abuau referring to the World Health Assembly resolution of last year about integrated diagnostics. Nancy Bowen was part of the expert panel that went to Switzerland in 2019 to come up with the original idea and develop the documents that eventually ended up with the World Health Assembly resolution. So she is very well fitted to speak on this topic. Mkaribisheni kwa makofi.
Thank you, Dr. Kimani, and thank you for the introduction. I'm back here again. I was the co-chair, but now I'm presenting on behalf of really my bosses who were supposed to present in the first presentation. And this time I want to take you through how far we have gone in decentralizing services, lessons learned from the viral load testing. So the outline of my presentation will take you through to understand how viral load testing in Kenya, where we are, how we have aligned to the government of Kenya vision and WHO also guidance on diagnostic or decentralization and optimization, and opportunities which we have in HIV program, which can be leveraged for the integration to support other diseases. The roadmap of decentralization, where we are at the moment and who have embraced the decentralization, because we are decentralizing services out of the facilities which started doing the viral load testing, and you will see that it started from research facilities, but we are now empowering and taking this as a service near the people by taking them to the counties. One of the things, again, we saw when we are decentralizing is that we need a leadership buying in from the counties, and you'll see an example of what has happened in some of the counties. And the last slide will be talking on the future of integration when we have decentralized fully. Thanks. So this is, I think you all know, some of you may know that we have 12 conventional labs in the country which does the viral load testing, even though we are moving towards, we are adding more of the 10 facilities as we decentralize. Within these 12 conventional labs, you can see they are based in six towns. One, as you can see from the map, one is in Busia, Kemri Lab, Kisumu, Kemri Lab, Eldoret, Ampath, Kericho, and Nairobi. We have about 7 within Nairobi. One of them is the National HIV Reference Lab, KNH, and I think Dr. Mecha is within the KNH. Kemri, EDAB, it was our new baby, but now it has grown because we have had more. That is the KU, Nyumbani, and DOD. And then we have one here in Mombasa. And you can see the way samples were moving to, we were taking samples. We have a robust sample referral network which serves the whole country. And when you see that map, you see how samples move through networking to this testing lab. And when you see the labs again, they are more concentrated to the western region just because they were following the burden of the disease. So these labs which we have at the moment is really, I could say, fully funded, supported, but not all, about 3/4, and mainly through PEFA. And what PEFA does is really supporting procurement of commodities through the program, equipment placements. All these equipments we are using in HIV are through placements, meaning we get the equipment. The importance of the placement of equipment is really when the equipment is obsolete, they are removed and they give us new technologies. HR, again, PEFA supports some of the HRs in some of these testing labs, so they complement the ones which are within the lab. Quality management system, in terms of accreditation, I know we are supported again through PEFA, and county have chipped in as well. Network coordination, we have a lab technical working group which really coordinates this, and most of the members of the technical working group are the, we have PEFA, MOH, and within the PEFA we have CDC, USID, and DOD. And again, they support the biosafety and waste management. In terms of testing performance, you can see in pre-COVID, the testing was, we were doing above 1.4 million tests. But after COVID, you know, all of us, the challenges we experience, even though we are picking up now, we have not gone back to where we were before the COVID. And if you can see, what you can pick from these pictures or graph is really where testing is happening more is at the research facilities. The first 4 or 5 testing labs are from Kemri. So in terms of decentralization, our first phase, we are doing not really decentralizing, but removing, transitioning the testing workload from this research lab to county lab. And I will tell you where we have started from. Even now, if you can still see the testing happening, the workload more is within the Kemri labs. So what are we? Yeah, we are alignment to government or Kenya vision, where we are. There is integration and moving towards the integration of or the vision of UHC and PHC and Vision 2030. The MOH declared intention to move molecular lab testing to the nearer to the people. But because these equipments are huge and it still have high capacity, and also training is is really high. It's a specialized testing. The only place we can move to is to the counties, and we are moving in phasing approach. And I think what the number, because of that high throughput equipment, we can only manage to move slowly to the 10 facility. I think that's what we captured in our strategic plan from the program, and also the PEFA have aligned to that. Again, as we do this decentralization, we need county leadership as a key, so that when they own it, they are sure on sustainability. So movement is to support integration services. What are the benefits of decentralization and integration? Mostly is really to reduce the turnaround time when we take it nearer to the people. And you will, I think if Mogori are here, or representative, they will tell us what has happened, because they are the first county which have embraced that. So they reduce the turnaround time, increase access again to multi-disease. When you get these equipments, and it has also been mentioned by our first presenter, by Roach, that the equipment can be able to do multi-disease or many. Apart from HIV, they have opened up again to do more than one. And it's not only one equipment, but we have 3 platforms at the moment. So all of them, I think when technology moves, every manufacturer gets aligned to what is happening. So all of them, the 3 equipments we are using at HIV testing, can do multi-disease. It also supports efficiency from reduced transport distance. Like I can still use Migori, because when we went there to launch the testing, they were telling us, I think they were being served by Ampath, and samples could take about, I think, how many hours to reach Ampath. They could leave 2 days, and the results again could come back, even though their turnaround time was quick, but transporting the samples was hectic. So they have appreciated that, and they will be able to support the nearer counties. Efficiency, again, we have said transporting distance and sharing testing resources. I think we experienced this, and it has been mentioned again by the presenters, that when we used the equipment for COVID, I think we saw the resources being shared, that support came from COVID. And if you open up again for integration, in fact, that is one of the benefits, that you can share whatever you are using for the equipment. This is what I think we are aligning to the WHO vision, and that is what was the meeting which we held in 2019, was really moving towards integration. And this was noted because equipments, I think parallel the silos program, we were buying or placing equipments separately for, specifically for HIV, TB, and other diseases. And it was noted that whatever the equipment was in TB could do HIV. And whatever we have now in HIV could do many services. So we were called to agree on methodologies on how to leverage and support each other. And the main topic within that molecular diagnostic integration was really to optimize the equipment we have in separate programs, which one can do more tests and which one cannot. We can also ride on the systems, like when we have systems which supports HIV, can they be used from other programs than to have different systems from different programs? And that's what we have seen now when we have opened up and used our equipments. When we are supporting now oncology for HPV, we are riding again on the same systems. And the results are within the same dashboard which we are using for viral load and EID. And the end point is really to support the patient being in one-stop shop and getting results for various diseases or biomarkers. Opportunities for decentralization and integration is we have already guidelines which supports the scale-up plan for viral load, so other programs can still ride on that. Where did we start from viral load and what can benefit from other programs? We have multi-disease testing guidelines which we developed when we noted that even the point of care we had before, which was Gene Expert could do out of TB, it could do HIV. So we developed a policy guidelines, but now we are reviewing it to accommodate other diseases. So we have those in place. Sustainability framework documents, we are working on that. We are even again working on integrated sample referral network to accommodate all tests, because we can leverage what is happening. If we are doing remote logging for HIV, why can we not do remote logging for other diseases to the same platform or centralized lab? Conducive infrastructure. We know at the counties there were so many supports for infrastructure or supporting building up all laboratories. We are leveraging, even at the moment as we decentralize, we went accessing the sites which were built by World Bank, Global Fund, and seeing which one fits, where can we go straight and decentralize the services. And we appreciate the donors which supported that. Counties have made commitments to provide HRH or human resource. I think when we did the assessment, whatever we're asking the county which moved faster really gave out in and say, we will support human resource, we will support what you tell us, and that's how we are moving. We ride on whatever they have. Quality management system, we know at the moment over 100 county laboratories are accredited, and most whatever we are, when we decentralize services to these counties or what we are using at the moment for molecular testing, we want a lab which is accredited. And based on that, having 100 county labs, we know we have a place just to move in. Current molecular equipment have ability of multiplexing, as I mentioned, and even now, the first site which we have decentralized a service, that is Mugori, they have started using the equipment for HPV, and that's a plus to them. What was the roadmap of what we did in decentralization, really, to support or to ride on that is and I think we are all quoting Professor Kimayo when he said, before you do anything, do plan. So that's the thing we did first. We plan when we talk to ourselves as the team and said, if we want to align to the guidelines given, we want to add more county labs, what is the steps we are going to do? So I think the programs, different programs put the scale-up plans into their work plans. PEFA, I think in our COP 23 or 24, we had 23, we also put that as a priority that we need to decentralize testing to 10 counties. But our first decentralization, we really said, our first one was moving testing out of KEMRI labs to county labs. And that's why we again engage the KEMRI leadership on sensitization and agreeing with them on how, and our first site is, that's why we concentrated in the western region, because we have KEMRI, Alube, moving to KEMRI, moving to county, Busia County Lab, and Kisumu moving to Kisumu DH. Migori was to support the Western region, Nyanza region. In terms of roadmap, again, we had to form an active decentralization technical committee within the same technical working group for the lab, and we are now operationalizing it this year. So the committee met, and this is the steps. So this is practically what happened in ongoing decentralization. The first thing is we went out for stakeholders engagement, and that is meeting the counties we identified. And I told you, because we went straight to Western region because that's our first phase of decentralization, using transitioning from the county Kemri labs to the county lab. So introductory to the meeting with the county, and the good thing, the county leadership are on it. And the leadership I mean is the governors, and through the CEC. We did a baseline assessment to the identified labs, but the identified analysis or gaps which were identified, we got support again from PEFA through AMREF, and their implementing partners inside. CHEP for both Migori and Kisumu. Dumisha Afya from USAID is supporting Busia and the county government. So the big chunk is really taken by the county, because they are the ones who have supporting the infrastructure, the human resource, and other things like, I think most of the things was, we are telling a county we need a three-phase electricity, power to support the equipments. And the faster they support that is when the movement of the equipments. Capacity building, I think that's what we are supporting them. From the existing 12 labs, they are the ones who have capacity to train the new county labs. So the first training which has happened was in Kisumu and Ampath. And why the two sites is because those are the sites which have huge workload and the capacity to support training. So they are taken through how to develop SOPs, assay verification, and all what entails to have a conventional lab. Equipment placement, we place the same equipments which we have at the central lab, and those equipments are 3 of them. We have Abbott Alinity, Roche, either C88 or C68. The names is because of the size of the equipment and the logic. All these 3 equipments have capacity to do multi-testing or multiplexing. And when we take it to the counties, I wish you can see the way they are so happy to receive it, and they, some of them thought it was, it's the way the picture which we were shared by Mecha, it looks a new state-of-the-art laboratory. You won't believe you are in Migori or those sites you are going. Implementation and monitoring. So the facility are sensitized on how the sample networking will move from different facility now to their nearest lab. Sample networking, we are doing now sample networking as we decentralize, because we are moving some of the sites which we are taking to a different lab to a new lab. Monitoring and scale up is ongoing. So this is the first lab we have decentralized. So you clap for Migori. And you can see the way who is opening it, the governor for Migori. So I said for something to be taken, that's a lesson learned. For it to be embraced, if you engage the leadership from above, I think that's what they really like. And somehow it's political. Some take it as that governor has brought a new equipment, even though us as from Medic side, we are saying we are supporting them. So we know the essence of it. We take them through, and they are really eagerly, and they are saying they will even support, they will use for other multi-disease. And whatever the equipments they are getting, they can do more than 3 or 5 diseases or 13. I think the manufacturers can confirm that. So the next county we are moving to, or we are waiting for them to say we are ready, is Kisumu and Busia. And they are in the lineup. So we don't know who will be the first. It depends on the CEC. But I know by when we visited, the next we are thinking Kisumu will be the first, but I don't know. If Busia goes first, we are ready to do that. So this is the story, I mean the short things, what happened that Migori became the first. The county commitment to human resource, county was already accredited, so, and I told you that's the criteria we use. County upgraded infrastructure, including a 3-phase power. I think that most of the equipments we get, if you will see the picture, it needs so much power. So the first thing is to tell the county, can you afford, can you support the 3-phase power? So Migori was ready, and I think Dr. Okada from Kisumu said, when we went to Kisumu, he said, I was the one who put the power, even though I could have been the first. But now we are following him in Kisumu. Collaboration with the neighboring counties, Migori will be able to take up Homa Bay, which they used to take samples to Kisumu. We are also aligning the national health agenda to UHC through PHC, as I had mentioned, aligning integration strategies, including uptake of multi-disease testing and integrated sample referral. So when they get the equipments, you are telling them, for now, we are supporting HIV, even in terms of commodities and any other things. But if you open up to do other tests, it's the county to procure those reagents. But they are ready when we saw, yeah. So aligning again with the national strategic roadmap. The integration again, the good thing is you integrate lab system. I had mentioned we were doing remote logging through EMR for viral load samples and EID, but now you can do remote logging for all samples. The rider picks the samples with the complete manifest. You can still do for different tests. Riders collect samples to a mapping facility, and you can deliver to the hubs. So if you integrate again all this, it becomes easier for one rider to pick several samples for different tests to a testing lab, and the testing lab will be able to do the multi-disease. And so the integrated system goes through the 3 steps of laboratory, pre-analytic, analytic stage, and post-analytic. Those are the equipments we place at the moment, and that's what I've said. And you can't believe this is in Migori. So if you see Migori now, it's a different lab or a different, it looks like a state-of-the-art laboratory. So when we move we decentralize to all the counties, this is how it will look. So it comes with the equipment, it comes because you have to have freezers to keep samples, and so it supports your accreditation. And obviously, if you have this, you'll always be passing your accreditation because you have to maintain so many things. What is the future? The future is really I've mentioned we did a diagnostic network optimization using the available equipments we have in country, the conventional equipments, the 3 equipments I've just shown you for HIV viral load, and the 2 points of care we have in country, which supports TB, HPV, and HIV. And this is the outcome of the map on how it will happen for us everyone to reach out 100% access the pointed, you can see the black spots are where the point of care will be put. And that point of care is also a multi-disease point of care, and would be able to do HIV, TB, and HPV, and other equipments, other diseases we can utilize the same. I think CTNG as well can use the point of care and conventional. So the 4 stars are the new conventionals based on the diagnostic network optimization. And these 4 are indicated to be shown that there should be one in Nakuru. It's giving us that one, we need to put a conventional in Nakuru, one in Kitui, somewhere in Kitui, another one in Tarekanidi, and another one in Migori, as we have put already. So we put those data, and the DNO is really capturing, it does this using a geo-mapping based on data-driven, and the data shows where do you think to want, what is the coverage you want to reach, and who are your target group. And this is the outcome of the DNO. So that is where the picture will look like when we do that. Reimagining sustainability integrated lab system. So decentralization will improve access, efficiency, and timeliness. Integration is happening at different levels. As I mentioned, data management for remote logging and sample transmission, sample transportation by doing integrated specimen referral system, equipment placement for multi-disease and multiplexing. As it has been mentioned again, multi-disease testing really is one equipment doing many tests, and multiplexing is one sample giving out different biomarkers. HRH is also lab personnel being given, using one personnel to do many tests, not really parallel as before. Commodity management and supply chain, lab reagent versus sample collection. It means when you are buying reagents for one platform for different diseases, the cost is reduced automatically if you negotiate by that. So this is the lab capacity building now happening for future disease threats. Oh, sorry. So this is the next step. I've mentioned we went to Kisumu, and through the CEC, Dr. Kada, we managed to see the governor there, and we are very sure that Kisumu is moving faster because we met him, and according to Professor Nyang, he wanted it to launch it this month, but I think they must be working on it. Dr. Helen is here to confirm that. So this is how, if you involve the leadership, they embrace it and they support you for decentralization. So I'm closing with this quote from Robin Sharban that change is hard at first, messy in the middle, and gorgeous at the end. Asanteni. I forgot to acknowledge my team, the testing lab, the techno working group, the program, and everyone who supported this. Thank you.
Thank you very much, Nancy, my co-chair, for that presentation. Thank you for showing us the context of the viral load testing in the country, how you are aligned to government priorities, as well as the WHO, the different multi-level impact of integration, not only the technology, the health systems, the patient, eventually the patient. You showed how you have been meticulous in planning. Every step is well planned. Decisions of where to place the equipment is based on data and geo-mapping, so that's very beautiful. And you have also showed us how some counties have been able to move ahead because they were ready to face the difficult change. They are ready to be messy, but they know it will be gorgeous at the end. So for me, that calls for a small celebration, and I want to ask Kipkerich to come and lead us to celebrate the people who are bold, led by Nancy Bowen, who I said has led the viral load services for the last 12 years. I think even those counties have really done well. Migori, Kisumu, Busia, because you can see state-of-the-art labs now moving to the counties and to the periphery. So before we call the panel to answer questions from the team, I think it is just right to celebrate them, isn't it? Keep.
Thank you very much, team. My name is Kerich. My work is very simple. We are in celebratory mood, and I think I'll be calling Kayamba, Africa, to take their space, and we are requesting that we are celebrating. We need them to give us their signature tune, and we want to appreciate for the leadership. I need Director Nascop to come up front. I need our partners who are supporting this process to come here in front, so that we need to appreciate Migori in a special way also, because they have done us proud. They are the new kid in the block. And kindly move, Kayamba, our partners. Daktari, come in front. As we do this, I request Migori County to stand. Kindly stand, Migori County. Migori, come in front. Technical working group. Technical working group. I'm seeing this excitement. We can feel it. Kisumu County, kindly. Kisumu County, we're proud of you. I'm told the three-phase power is already there. Mali safi. Hold DJ, hold. Nancy is not yet celebrating, wait a bit. Kisumu County. Dr. Ogola. For the good work that they've done. Busia County, they are to join this team. And this is decentralization, as Daktari. As Professor Kimayo said, that if we are not careful, parasitism is not something attractive. And we must put in money. Migori County has put in money. Kisumu County has put in money. Busia County has put in money. So here there's no parasitism. We appreciate you, Kimayo. You also trained those people. They were trained in Ampath and Kisi and Kisumu. We really appreciate. So let the music begin. We can start with Kisumu, of course, and Nyanza region. If you can give us your signature tune, especially Osogo Winyo, we will be very happy. Can we raise our hands? Thank you, thank you, thank you, thank you, thank you, thank you. Thanks a lot.
Mali Safi, that was special dedication to Nancy Bowen. So thank you very much. Right now we still have a few minutes. We say the program ends at 9. So any questions for Nancy, for John Abuau, for Dr. Mecha, and even the morning speakers? We still have Dr. Mboro from Muranga. I don't know if Dr. Wesonga is still around, but we have Dr. Mburu still present. So if we have a few questions for those, starting with Prof. We have a mic. Do we have a roving mic? Any others we can cue the questions? Yeah, Brian, so start with Prof.
1, 2.
Thank you. Congratulations to the lab. Nancy, thank you. But I'll ask a difficult question. I've had a chance to interact with a molecular level lab. The Kesha-Bora study required us to have that level of lab capacity at the university. And the department I work for is a department of pediatrics. So we needed to work with our neighbors who are immunology lab. And the lessons I took away from that exercise is that this level of molecular laboratory work needs the backing of fairly well-trained molecular scientists. And so my question is, as Migori puts together that molecular lab, are you building a capacity for supporting that work? Do you have people, masters, doctoral, postdocs, working in relationship to your lab so that they help you to maintain the high standard of work, but also help you to develop a repository that can allow you to do disease surveillance? You know, the lab equipment can be like a new car. You know, it's great when it's in the shop, but when it comes home, it's good for a while, and then it becomes obsolete. So I really think that has to be thought through very seriously. Dr. Mao, who's not here today, started the lab at the early infant diagnosis at Kemri, and also out there in Western Kenya. And a lot of that work was being supported by students who are in some various universities, particularly in Nairobi, who are doing biochemistry or those basic science subjects. And I remember having this discussion how they were not employed. They would even walk to Kemri. They were totally inspired to actually do this early infant diagnosis and make a difference for the kids. And he himself is a highly qualified molecular scientist. In fact, you remember he got the Queen Elizabeth Award for his work at Oxford University. So my question is, you get a molecular lab in Migori, you get one at Kisumu, you get one in Busia. How do you sustain that long term? You know, are we training the people who will be able to do that? I know from the point of view of training of pathologists, because usually pathologists are part of being team leaders in the lab, we're not doing very well in terms of numbers. During COVID, I think there were only 16 pathologists employed in the Ministry of Health for the whole country. I don't think every county has a pathologist. So I think we need to think through that plan. That alongside it must come the capacity building. It's not enough to be a lab tech to run those high-level laboratories. I think, Dr. Rose, that's something you need to think through going forward.
Thank you very much, Prof. We can have Brian, then Dorothy.
Mine will be a quick question. As we were looking at the future of Lab Network, have we also taken into account the One Health strategy and how not just multiple disease platforms, but also for animals as well, that we could take that into account as well?
Thank you. Can pass it over.
Thank you. My name is Dorothy Onyango. I'm from Women Fighting AIDS in Kenya, WOFAC. There was Dr. Aching, who presented on the research this morning of the new coming ARVs, and especially for some of us who are now aging with HIV. I know we were very excited when we had DTG come in and all of us were running in and pushing everybody. But now we have realized that we are actually aging with HIV. And of course, there are new regimes that have come, and I think she talked about TAF. So my question is, how long are we going to wait for this? Because our bones are not waiting. So probably Dr. Rose, in the absence of Aching, how soon are these people aging with HIV going to get this regime administered to them? Thank you.
Thank you. There's two more questions, one that end and one very back there. We can take that set.
Thank you very much. I have a question to Dr. Mecha. Okay. Can you hear me?
Yes.
Dr. Mecha presented some very nice achievements, especially after the East Lab stopped getting funding from 2021, and since that time they have been able to sustain their programs very well, and even there are more numbers really on their testing program. Can he just share with us the trick? If there's anything the government labs can learn, what is this that they have done to sustain that effort? Thank you.
Thank you. One last one at the back.
Hi, good afternoon, good evening to all of us. My name is Wamboi Nyeke Salome from of ICW Kenya. ICW is International Community of Women Living with HIV and AIDS, the Kenya chapter. My question or questions, they're free. One is about data. How safe is my information? Especially matters the integration and all that. Secondly, are we sharing this data in, as in per county, that is, are they inter-county from level 3 all the way to level 5? Because majority are talking about going paperless. And we have an incident where I have been diagnosed with maybe TB at level 4, maybe it's a skeletal TB, and I need an advanced treatment or diagnosis from a level 5. Do I carry my papers all the way to level 5, or there is a way that the data has been channeled now to level 5 as per my county? Then the issue of these diagnostic lab machines and all that, how affordable are they to the Wanjiko? How sustainable are these to the Wanjiko? Are we in a position to push these forward and all these? I want to maybe ask or share what we went through some times back. Was that, I think it was Bamako or something, where dispensaries were supposed to pay around 10 bob or 20 bob or anything. Are we coming up with a strategy where the other regime that will come will face out what we have done, all in the name of removing evidence or removing our achievement, then they come up with their own thing. So I think we need to work on that. Are there policies that will stamp whatever we are doing such that whoever else will come in, that CEC, that director, will not erase our evidence? Thank you.
Yeah, thank you very much. I think we can start with that set. So the first question is about capacity building for the people working in the labs. For example, Migori. I'll request Nancy to comment on that, as well as Dr. Mecha, because you're in the training program. And someone from Migori, we understand the capacity that has been built. Yes.
Thank you. And thank you, Prof. I think she's out. But I wanted to confirm that, and I think in my presentation I mentioned about capacity building for the people who are trained. And the first thing in even our assessment, we were reaching out to the counties to make sure that we have people who have certain level of training for us to train them. But I confirm that the labs techs we have at the moment have capacity to do that, molecular testing. So there's nothing different from our referent labs or where other testing is happening. It's only to get those people and we train them. And we are assuring, we have already confirmed the competencies. So that was one of the criteria we were following as we decentralize.
Thank you. You can take two more. The one of, when you are doing the mapping, are you considering the One Health approach where even animals can utilize the same labs?
I don't know how to say it, but I think the DNO we did at first was really based on the 3 diseases, but I mentioned that we can still redo other mapping as well. But we are learning from the 3 as an integrated network optimization based on the equipments we had at the moment, which can do that. But I think it's open. And I think there are forums for One Health.
Mm-hmm.
Yeah.
Okay, thank you. You can also take the last one, talking about when you have these big platforms, how is the costing going to be, and can it be affordable, and will there be policies to ensure that the tests remain accessible?
Is that Rose? Maybe you can help me, but yeah.
The question was from Wamboi Nyoike, and she's worried that with all these equipment, maybe in future, the services may not be affordable. What is the policy direction to ensure that they will be able to still afford the lab services?
Well, thank you, Wamboi, for that question. I think my current understanding is there are several things to look at when you're discussing sustainability, affordability, and accessibility of the services now and in the future. Decentralization is just one of the mechanisms. Integration is just one. But I think financing is another component that is a discussion that maybe we haven't gone into it. Because the same would be the question we ask for ARVs. When we started ARVs, we were doing referral facilities only. We went to district hospitals, we went down. And then there's the issue of how we can ensure that there is affordable, accessible ART and the financing of the same. So I think it's an important question. As we go into the financing as an issue, it will be important to then look at what are the policies that support that. I believe what the lab has demonstrated is that decentralization in itself is an intervention and integral as we think sustainability, just like integration is one. But there are many other things, including domestic financing, both at all levels, whether you're looking at national or county level. My hope is that given that there is already a lot of reforms around UHC and financing, there is an opportunity to, as we look at financing and domestic financing, to look at the whole scope of things.
Thank you very much for that timely response. And also, Wambui, to let you know, so for example, when you have volumes of testing, so if the equipment was doing 1,000 viral load tests, and now you can do an additional 1,000 HPV test, another additional TB test, another additional, so what we call the economies of scale, it means that you're using the same platform with big numbers. Ideally, the cost should actually be better than if you're only using it for one. Dr. Rose, since you still have the mic, you can address Dorothy's question about when will the TAF be available, especially to those who are aging.
Thank you, Dorothy, for the question. My take is the current guidelines does acknowledge the place of TAF for special populations. And as a program, in the current quantification, planning, and projection, we have made some provision for the populations based on evidence and published science. I think we worked with about around 8%, with the willingness to try in the first year, gather local evidence or justification for the initiation of clients on that. We have a team that is working on the actual implementation, and we hope that in the next 1 or 2 years we'll have local adaptable practicality of how to actually prioritize those clients. So there's the value, but there's how to apply within the program that we are now starting to see as we move forward. So in the current GC7 Global Fund, that was a key issue that we had to discuss across stakeholders, and we used the higher estimate of 8%, given that we didn't have local data of, at population level, how many would we plan with? We hope with that assumption, increasingly we'll be able to gather enough evidence. So yes, the plans are on board, and in the face of public health, we are doing our best to gather enough local data to properly quantify. But currently, yes, we've quantified, and we hope for the products to be on board for implementation.
Thank you very much. I know Dorothy had to ask that for that age, because in the morning we had the Gen Z who actually came, and we joined them in the picketing to demand for Kabele. The next question is for Dr. Mecha. Just speak about sustainability, even when donor funding declined, or how were you able to continue with the services? Thank you.
So, of course, we are an academic institution, so primarily what we do is train, do research. But, being the Faculty of Health Sciences, we also provide a service. So what I've learned from working in laboratory capacity building is that it's probably, if you asked me, the easiest to sustain. If there is visioning and commitment for people to apply themselves to what is required. I'll give up one example. While doing some work in places that I will not name, this particular public health facility was actually outsourcing laboratory services to a private lab when they had the equipment, the lab, the health resource, and everything that goes into it, including on top of that, external support for laboratory accreditation and all that. That's going on, but services are what? Outsourced to a private lab. Why? Because of reagent stockouts or equipment downtimes. So I would really say if you are providing a quality service, people will pay for it. And I think Dr. Fuller said we will be talking about financing. Whatever financing mechanism there is, people will be attracted to a lab that is providing quality service. That's number one. Number two, as I said, as these technologies are evolving, and we are increasingly realizing we need them. So let's give the example of oncology and targeted therapies. Do you know how much we are, paying out for genotyping? Okay, the cheapest you can get, because we are not doing it in Kenya, is about 200,000 Kenya shillings for one panel. If you want to do an oncology, colorectal panel or lung cancer or something like that. It's anything between 170 and 200,000. Why aren't we doing it? I think Prof asked about molecular biologists and other people that can help with that. So if you asked me, with visioning, commitment, and really what it takes to manage these things, laboratory is probably the easiest to sustain. So what we have done is provided a service that is of quality, and therefore researchers, people who have research that they want to do are coming, and that is the fee that is helping us, provide this service, continue to provide this service. Training, doctoral students, postdoctoral students, MSc students are paying a bench fee to learn these molecular techniques, and that's also helping, and a couple of other things. Thank you.
Yeah, thank you very much, Dr. Mecha. The last two questions, I kept Dr. Mboro waiting because he was my classmate. From Wamboi Nyoike, she's asking, this information that you are collecting, is it safe? Secondly, if she has to move from a level 2 to level 5, do you need to carry the documents, or is this information moving across? Thank you.
Thank you very much. I think that's a very pertinent question, and it calls to further discussions on what we alluded to earlier through myself and other presenters on data protection and the Data Protection Act ecosystem. One is that, for example, as we work in the field of the AFIA KE, the system has inbuilt protection layers at various levels. One, you realize we talked about at institutional level, you have to be licensed as a data processor and a data controller. And in that, there are inbuilt responsibilities to the institution once basically now you acquire those two status. So that is the level at the institutional level. Of course, the system itself, there is certification Like it was mentioned, because there are various HMISs, and for them to be in the digital superhighway that we discussed in the morning, they will of course have to be accredited through that certification. Now, going down to the individual service delivery points, the human resource, of course, people now to access the system, you have also to sign into some ethical code, of course, for any ethical practice to happen. And finally is that visibility also is at different levels depending on the credentials each person has. So what visibility the person at the lab has is different from accounts, is different from the administrator, and is different from the clinician. And of course, it's also work in progress. Portability of data, of course, is another discussion to answer the second question. And remember, we said that there is even self-registration of the client themselves. They self-register into the system, but what is now available at that level is the biodata. Finally, of course, because data will be utilized in other areas, research and all that, that is a whole other ecosystem with a lot of inbuilt ethical, inbuilt mechanisms, including coding, where now it is not the bio-identifiers that will be visible, but basically a code. Thank you.
Thank you very much. I think that was comprehensive. I think for the sake of time, even though we said we are ending at 9, we need to transition to another session, but let's just appreciate the answers that we've been provided. So at this point, we are very privileged to have the head of NASCOP, who is the convener of this gathering. And Dr. Grace Rabut has given me the privilege to actually invite her to the podium to make comments and remarks and guide on the next steps. But I really want to appreciate Dr. Rose because of one thing. I think the duration she said this summit needs to happen, I actually thought this was unachievable. But looking at it today, how quickly this was done and how impactful it has been, I remember the words of Nelson Mandela that it always looks impossible until it is done. And here it is, the summit has happened, it's happened, and it's so exciting. So I really want to appreciate your leadership as I call you here. I'm still reading the last slide of Nancy, saying that change is hard at first, messy in the middle, and gorgeous at the end. And Rose has been bold enough to lead the change. Thank you and welcome.
Good afternoon. Good evening. I have missed the morning discussions. Today, is this mic on? Okay, today I had to do some side meetings from morning. I realized that I usually finish meetings and then I have meetings until 10 p.m. Then I go look for food. So I was getting exhausted. So today I sat at the reception and I had meetings until 2 p.m. Went for a late lunch. Just that tells you that one of the objectives of fostering new collaborations is working. I'm hoping you've also had moments to foster new collaborations. I hope hausikii tu na unanyamaza. Ukisikia mtu anafanyia mtu kitu, unamtafuta. That was part of the purpose of this forum. It was to allow people to know people and to interact at personal, at organizational level. I would like to thank you so much, those both inside and those outside, for the engaging and committed participation that we have had. as Kimani said, and Dr. Ngugi, actually they're the ones who pushed me. Let me confess, Brian. These guys, Kimani and Ngugi, came to my office. Not 2 months have not passed. Started telling me, you know, we could just have a small team, be meeting in your office, and you know. And then I asked them, but what exactly is going on around integration? Said, we could find out from counties. This summit is finding out what is going on. Because we must start from a point of what is going on before we start sitting in Afi House and saying things that may be not in line with the reality on the ground. So I really want to thank you, Dr. Kimani and Dr. Evelyn Ngugi, for starting that conversation and committing to be in NASCOP. Jen, when they were not there, truly they were in NASCOP. So, and they deserve a pay rise. So I think I want to just say we've had rich conversations. Tomorrow is the closing. Tonight we were to have awards, but I've been requested to consider doing it tomorrow when the Parliamentary Committee for Health is around. It is important for, you know, leadership to see some of the great work that is out there. So for that reason, we will rest this evening and tomorrow try and have a small session of the certificates of true awards to the work that has been done. And I look forward to celebrating with many more who have done a great job. We missed some experiences. We had planned for a community village. I think I enjoyed the Naivasha one. I listened to stories, and it was quite encouraging. Unfortunately, we didn't have that. We also had county villages. We didn't do that. I think as we break, you may want to optimize some of the opportunities. May not be as optimal, but you can meet a few people and have your village kidogo. There are those who organize villages in the beach and some places called Chachoma. So I'm hoping the villages can continue in the evening. There are also exhibition and networkings that can happen. I remain indebted to you. So tomorrow we'll organize the program, and hopefully let's start early with the members of parliament being around. Would like to finish in good time. So I urge us to be here by 8:30 so that we start with them. With that, asanteni sana, and may God bless you. I hand over to Jonah.
Thank you, Head NASCOP. I feel that we need to appreciate her better, and so that for the bringing us together and also making sure that it has happened. Who's going to lead us in that? I'm going to dedicate this to Casco Busia. Uko wapi? Utuongoze ku appreciate Head NASCOP for that. Kindly. Thank you, thank you. Yes. All right, Dr. Helen, come and guide us in that. I think I can see you've been selected for that. Kindly come. Thank you.
Thank you. I'm standing in for my neighbor, the Busia Casco, and she's just getting in. Now that she's in, while you are away, Dr. you were selected to come and lead us in appreciating Dr. Rose. So as a good neighbor, I was standing in for you. So do I continue or do I hand over the... No, Senje anakuja. You know, where we were born, we have to follow protocol.
So do I dance or we appreciate first? We dance. Kindly come over. Okay, thank you so much. Thank you everyone who stood up to appreciate our mom. We really appreciate your efforts. We are glad. There is no other way we would have done it better. I think that was the best appreciation. Thank you so much.
Thank you. To all of us, I want to appreciate us and for being attentive and also for contributing to the success of today's activities. We've really learned a lot on what it requires for us to have an effective integration towards service delivery. One of the presenters mentioned earlier that we should not see integration as the end, but rather as the means towards the end of what we desire of our clients. And I believe through the sessions that we've been taken through today, we've learned a lot, and we will continue reaching out to the respective presenters so that we keep on learning more from them. And also the call from the AYPs, at least, that was very powerful, especially on the call for action that they are ready to go. What they need is continued engage, and continued engagement. So thank you all, and since today is, the weather looks okay for us, so I want us to end it early so that we can be able to get time to at least appreciate Mombasa. And thank you all, and looking forward to meeting again tomorrow morning. Before that, we want to close with a word of prayer from one of the counties, that is Mandera. Sijui kama wako? Mandera? Marsabit? Any representative from the Asal area? Thank you. So karibu sana, you lead us in a word of prayer as we close today's session, and God bless you. Thank you.
Okay, we shall be praying. We will just remain seated I will say a short prayer in Arabic. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. Thank you.
Thank you, and God bless you. Bye.
The HIV pandemic is now 40 years as an isolated outbreak among specific communities. This has evolved over time to be a global pandemic, a life-threatening condition, and later on a chronic condition, as we see now. In the year 2022, NASCOP released the new guidelines. As an isolated outbreak among specific communities. This has evolved over time to be a global pandemic, a life-threatening condition, and later on a chronic condition, as we see now. In the year 2022, NASCOP released the new guidelines in terms of management of care for patients, and amongst the key highlights were the integration of non-communicable diseases in management of HIV. Over time, we're seeing patients with HIV living longer and also developing other conditions like non-communicable diseases, like hypertension, diabetes, amongst others, including cancers. And therefore, there was need to also look into these diseases, these chronic diseases. Nakuru County has moved to embrace these new guidelines, and even further than that, we have moved towards integration of health services, so whereby HIV is treated like any other chronic disease, and our clinicians, our doctors are able to attend to all patients together. This is very important because it not only allows for integration of services, but also reduces discrimination and stigma, and at the same time addresses the patient as a whole. In addition to that, we are able to have healthcare workers who are all rounded, unlike before where we had healthcare workers who specialize in HIV, TB line, and are not well versed in the other sectors of healthcare. So we have been able to integrate HIV care in many facilities. We have started with a low volume and 4 facilities, for instance, in which are easier to deploy because the numbers are fewer, and this has really helped us because we are able to cater for, to see a larger number of patients by the same clinician because they are able to cut across both conditions in terms of HIV and ordinary conditions. Moving forward, we are also using the automation of healthcare services as an enabler, using the Kenya expanded EMR system, we are able to have an end-to-end system in all our facilities, which enables any clinician at any point of care to be able to attend to all manner of patients, be it HIV patients, diabetics, hypertensive, in an integrated manner.
I'm here at a primary health center where we have been supporting HIV care, and we are here on World AIDS Day. They celebrate every year by bringing out the children for graduation who have been certified AIDS-free after receiving preventive treatment from deliveries with HIV-positive mothers. Today they celebrated 54 children who graduated HIV-free. It's 5 years with no child HIV deaths. It's an extraordinary thing to be here on World AIDS Day. Be well to you all.